So Ingrid Nemhard is from University of Pennsylvania. She is the Fishman Family President's Distinguished Professor in Healthcare Management at the Wharton School. I have been familiar with her work for quite a long time, and I'm a huge fan. So I was super excited that we finally had the opportunity to invite her to come. Her research focuses on characteristics of healthcare organizations, their leaders, and their staff, and how those factors all contribute to the implementation of new practices, organizational learning, and ultimately the quality of care. She has received a number of different awards, including the Academy of Management's Healthcare Management Division's 2023 Mid-Career Advancement Award. Before she went to the Wharton School, she was a tenured associate professor at the Yale School of Public Health. Their loss is Penn's gain. I could read through like a ton of other cool work.
That was already too much.
But there you go. But yes, we're super happy that you are here, and the presentation is going to be around staff burnout and ambulatory care. But
thank you. So thank you all for coming. I know it's odd to come to a seminar this week. This way we can distract ourselves. So I'm really thrilled to be here. When I got the invitation, I was very excited, having looked at this institute from a distance for a very long time, and actually getting my itinerary made me even more excited. It turns out that I overlap with many people in this group, and it was sort of a challenge to figure out what to present that might cross the variety of interest that would be in the room. And I decided to do this. I will say that I feel like this is a good choice because it does reflect two paths of my research. So for most of my career, I would say that I have spent quite a bit of time thinking about the work environment for healthcare professionals. And then later picked up a real interest in how do you also not just improve quality of care, but also how do you improve the patient care experience. And so these two worlds are going to converge in this particular presentation. But I'm happy to talk to people about any of the other things that I usually spend my time talking about. First, for this work that I'm going to be talking about today, which is really going to put us looking at the intersection of patient experience, patient narratives, and staff burnout, I have to acknowledge the phenomenal, first the team, not that ARC is not phenomenal, but the work that I do in this space is because I get to work with the phenomenal people who are on this list to do the exciting work that we do. And our work has been funded by ARC. So I just wanted to give a shout out to all of those entities. Any mistakes are my own on that as well. So what I thought I would do is begin with what I'm going to call my simple model of healthcare improvement. And to the extent that you want to think about improving patient experiences, I think you can begin with a central thesis of if you wanted to improve patient experiences, you would need to learn patient care experiences. And part of my research has been on organizational learning. And so for me, this comes together actually quite naturally. Like if you want improvement, you're going to have to learn from some sources that are available to you already. And then you have the possibility of actually improving. Now, if you were to take this as a model, it would suggest that you would begin with this idea of, well, let's ask patients about their experiences. They are a very reasonable information source. We would then analyze the data that they give us. That information would then come back to being shared with staff. And then you could take the ideas from staff and from patients and use those ideas to improve patient care experiences. Like that's a very simple way of thinking about it. And you can add all kinds of other variables to this, but streamlined, let's ask them, analyze the data, use the data, essentially. Now, I know probably I don't have to say this in this audience, but we've had a way that we've approached this first step in the process for a very long time. And that first step is let's look at our traditional closed-ended surveys. And for anybody who does work in patient experience, you're very familiar with this. Even if you don't do work in patient experience, we can test and see if you are familiar with this. How many of you have ever received a survey after going to a healthcare provider? Okay, not everyone, which is shocking to me. Some of you are lying. Just to be
leaving email.
Or maybe you didn't receive it because you deleted the email, so you can't actually claim to have received it. But for most of us, when we go to the doctor or someone we care about goes to the doctor, that is followed up by some kind of closed-ended survey. It can take, it can have questions that come from the agency Healthcare Research and Quality, CAPS questions. I'm part of the CAPS research team, so I look at those questions a lot. Or there are vendors like Press Katie that are doing this on behalf of healthcare providers. And most of those surveys have some of these that are listed down here. They have these measures of access to care, patient care, provider communication, care coordination, are the staff helpful, and some patient satisfaction measures. So how would you rate them on a 1 to 10 scale, willingness to recommend it to others? This is the way the world has operated. And in fact, the world will probably continue to operate along this with these surveys for a very long time to come. And there's good reason, right? So with survey data, you're getting a lot of data. You can look for the means and look for patterns of data. It's easy to collect. There's a lot of good reasons that we have this. We've learned a lot from these surveys over the years. Areas in which we've done pretty decently as healthcare providers, and areas where we can see opportunities for improvement. And I should say anybody can interrupt me, and our norm is not to be silent and important throughout, so like that, you won't throw me off. But I would say recently, I'm still going to consider this the new frontier. We've seen more interest in patient narratives. And quite simply, patient narratives are when you ask patients to share their stories about their care experiences and in their own words. So in surveys, we're giving them the words. We're saying, did you have X, Y, and Z? And those are our words. But the new frontier, as we think about patient experiences, asking, tell me your story and write it down for yourself or verbalize it for yourself. In some sense, that feels like a new frontier, but patients were starting to do that on their own. They were writing it on Angie's List. They were putting it on Yelp, Health Rates. They were already doing this movement. The new frontier is that healthcare organizations are actually soliciting these narratives and trying to collect them systematically and use them. Some organizations, not all. Some may be collecting, but maybe not using them. Do you have a question? No, just. So just to be clear, when I say patient narratives, we have a clear definition for that. So feedback from patients about their care experiences in their own words. There are many ways in which organizations solicit this kind of information. Most likely, if you're getting Tuskegee surveys, you're getting the 3-part, like, what did you like? What didn't you like? Tell me anything else you want to tell me. My colleagues, many of them on that first slide, were funded by ARC to develop what we call the narrative, was a narrative elicitation protocol. It's now the narrative item set. And it is an elicitation, 5 questions that you see here that at this point we know give more fulsome accounts of patients' experiences than the 3. So the most important things that you look for: how do they measure up in this provider setting? Anything that has gone well, anything you wish had gone differently, and then how do you and your provider relate? And there are many words around that. I'm just highlighting the key themes that come out of these questions. I will just say a lot of effort was put into coming up with these questions. And what we know at this point is that they do lead to pretty fulsome accounts of patients' experiences are able to do this. Just to give you a sense of when I'm talking about what does it mean for patients to give you their feedback in their own words, so I have snippets on this slide, just to give you a sense of how you can actually start to learn quite a bit from patients' experiences. So this patient says, my doctor was sincerely interested in my concerns, ordered lab tests, a procedure, and told me she would work with me until things were better. She walked out with me and made me feel as if she truly cared and would help me. I felt good about her caring. You won't get that close-ended surveys. And what I bolded are things that help us understand what would be part of a good experience. So you can, the subject in there is the doctor seeming interested, ordering appropriate lab tests, walking out with me, feeling cared for. You can start to see in these narratives what makes an experience a positive experience for patients. In the second narrative that you see at the bottom, just an excerpt, you can see what also feels like maybe a negative experience. So I'm talking to the clerks and they seem too busy when you come in, and I felt rushed and not listened to. So you can start to see the elements that may be quite important for patients to have good experiences. Now, this work has been being done for quite a while now, and so we have learned a couple of things that I think are instructive. Narratives, at this point, we know that they provide a series of things that we would think about as valuable information we want to improve the patient care experience. And if you're curious, in the data that we at this point have collected thousands and thousands of surveys and narratives, And about 69% of them have some narrative feedback. So those closed-ended questions usually have the narrative questions at the end of them. People get there and they will actually complete those. They want to share their stories. The information that we're seeing from them, I would say, falls into 4 categories at this point. So distinctive information. Many of those closed-ended survey questions, they give us a part of the story, but when you go to the narratives, you're actually able to learn what people mean when they check number 5 on a question. You actually also start to learn about distinctive domains that are not covered by those questions. So those, most of those have 4 domains in them or 9 domains if it's HCAHPS or at the hospital level, but you start to see all the things that are not covered by that are influencing those scores like provider rate. So there's distinctive information that comes from these narratives. You also get actionable information. So many of these narratives will end up giving us information about things that could be done differently. You could take different actions if you encounter these experiences. One of my colleagues, Lee at Columbia, has a particular interest in creative ideas. And we see in these narratives actually creative ideas for how you would improve patient care experiences. So patients will tell you, you could do X, Y, and Z, and that would make a better experience. We see information that we consider representative information. For anybody who does work with patients and uses surveys, you know that response rates for patients who are socioeconomically disadvantaged tends to be lower, whether they're older patients, racial ethnic minorities, different communities that are typically marginalized, they tend not to respond to surveys to the same degree. That's an issue, certainly, but what we're seeing with narratives is that they actually, patients in those demographic groups actually do respond to questions at the same rate. And so you're able to get a more fulsome, if they're only 10% that are going to respond, they're going to respond to those narrative questions. And so you start to get that data that you weren't going to receive any other way. And then finally,
can I make sure I'm understanding what you're saying? Because that's a little counterintuitive to me and totally fascinating. But are you saying that if they respond, they're more likely to provide narrative responses?
They respond to the narrative questions at the same rate.
Right. So other populations might respond to the survey at a 20% rate, but only half of them do the narrative, whereas a minoritized population might respond at 10%.
Right.
But 10%.
But they're going to also do the narrative questions.
Gotcha.
And so you get their stories.
Right.
And it's harder to get their stories in other ways. Or it can be. So we think that that's actually a valuable information that's coming out of these narratives for reaching other populations that we haven't been able to capture their information as much. And then motivating information. So a lot of these narratives, you can visualize what's happening with patients. You can imagine that rushed encounter. You could imagine somebody walking out with you and you feeling cared for. And what we know is that when you have image-rich content, emotional content, it can actually help healthcare professionals think about how they would make changes. It's motivating to professionals. So there are a lot of ways in which this can be really quite informative. I will just show you here. My team, so Rachel and Mark, have done beautiful work that has identified the different types of information you get, whether it's captures, closed-ended questions, it's elaborating on that, it offers new domains, the distal questions. Here's what's not. Here's sort of top 9 things that they have found are in that are not in the closed-ended, but you can get from narratives that patients say really matter to them. So when they write their stories, they're capturing the emotional side of care. Actually, really, what is the emotional rapport with the clinician? How efficient was the interaction? How thorough was it? What was the approach taken? Perhaps interesting. As they think about their patient care experiences, they also talk about their insurance and billing issues, which before I entered this work, I didn't think about that. In all honesty, I didn't think about that as something we needed to pay attention to in terms of patient care experiences. So you can learn quite a bit. My team, though, as I said, we are part of the CAHPS consortium. And we began to think about, it's interesting to get all of this information, but is there a connection between organizations actually using these narratives in CAHPS scores? Are the organizations that actually, and when I say use in our context of studying it, it's collecting this information, sharing it back with the staff, doing so kind of frequently, not once every 2 years, actually giving it to them in a regular, does that make a difference? Do we see that the patient care experience scores, both their operational measures and relation, are they better? Are these organizations doing something worthwhile by paying more attention to the narratives? And our work would suggest, yes, conditional on organizational attributes like staff competence. So, for example, where staff feel more confident and their organization is providing them with patient narratives, we see that combination leads to them having not causal use, cross-sectional work, but better scores on operational measures. And we see that. And so there is some indication that using the narratives can make a difference in patient care experience scores. If that's true, then we might think that actually the organization did something to improve patient care experience. What they do, and I was talking about this earlier, like that what it is they do, I think is still an opportunity for studying. How do you actually take that? And I'm not going to be able to show you that. So if you're hoping, oh, magically, she's going to tell me exactly how organizations do that, I'm sorry to disappoint you already. But there's indication that it does actually matter to be able to use the narratives.
So we've looked at upstream what drives whether or not organizations use the narratives. Like, are they more competitive markets, or I don't know, just sort of curious what motivates that.
Those are great questions, and we have not studied that yet. I would say that in the organizations that we have studied, leadership makes a big difference, right? Having a CXO who is thinking creatively about how to do this. Organizations where they have felt they haven't been able to move their patient care experience scores, and they need something new. The recognition that, okay, we've been collecting these closed-ended data for a while, we know what our scores are, still aren't moving the needle. We need to, the ones who are like, okay, we need to go out of the box a little bit and figure out what are we missing, what are we not getting. So some of that is like leadership and culture, and sort of in a market. In this work, we looked at the ambulatory care setting. But you can imagine, we're moving to the inpatient setting now. You can imagine in the inpatient setting where value-based payment is contingent on how you're performing on your patient experience scores. We're seeing more organizations that are excited about potentially doing research with us, because maybe you've got the secret sauce. Maybe there's something in those patient narratives.
When you say the narrative organizations using them, I mean, one thing I could see is that, their clinicians get the composite score from the structured data, and then they get the, kind of redacted narratives.
Yes.
Just as here's all your data.
Yes.
Figure out what you're.
Yes.
But it seems to me from an organizational perspective that that's a lot of natural language processing or hand reading. And I mean, doing surveys of RNs with open-ended questions, we've had surveys that came in the most recent years are like 1,000 open-ended responses, and it's a pain in the butt.
Yes.
So when they're using them, what are you typically seeing? Are you seeing that they're making an attempt to process them? Do they have some like, hey, summer intern, go read all this, or do they just push it out kind of as is, or and maybe it's all the above?
There's variety. So what we're seeing is variety in terms of that. So there are institutions in which, so for example, at MGH in their primary care initiative, Susan Edgman-Levitan apparently reads all of them. So she's part of this count. Like, she reads all of them that come through. They have flags, and they have, they won't say they're vendors, but they have ways of doing it automatically. And yet I think she also just reads all of them. There are places now that are using LLM, their quadric. The vendors are all applying LLM to this. So there's some of that happening. And then there are places in our research, we've also hand coded and trained humans to do it. And so the next step, the folks at RAND, who are also funded by the other consortium, they are doing more of the work looking at the LLM human coding. How much do they learn? So there's a lot of variety. We think there's a lot of potential. And I think for organizations to move forward with this, a lot of them are wanting the reassurance that they could use LLM and feel good about the results from that. And that's true for grievance reports too, not just this, but other forms of patient feedback. Can they use it? And this is just another data source. So the EHR, the notes, right? This is another data source that would inform what they're able to take. So there is a lot of variety. We did this work, and sort of the first step was for someone like me who's organizational, is being able to show effects of organizational outcomes. And so we wanted to, CAPS team, we needed to show, I think, connection to patient experience scores. But then we started to wonder, people started to ask about, well, you could be providing these scores, but in fact, narratives are giving feedback to people, right? So we use the term patient narratives, but that's actually performance feedback in some world. And is that the type of information that could actually have adverse effects on healthcare providers? It's one thing if it's on Angie's list or Yelp, but now you've made it part of the process and it's transparent in some cases in the organization. How does that feel to providers? And so we started to think, ask this question, is there a link between providers seeing patient narratives and feeling burned out? And if so, why? In this room, everybody knows about burnout, right? There are 3 dimensions of it. It's a syndrome. The World Health Organization said it's a person's crisis in their relationship. And I think for most of us, when we think about it, we think about this one in the green up there, which is emotional exhaustion for workers, but it has other components. You start to depersonalize your colleagues as well as patients. You start to feel less efficacious in your health work. Those 3 things together make for burnout. So there was this question sort of looming in the background for us about, okay, maybe we can improve scores. Maybe that's only in the short term, or eventually we're going to burn out people, and that's a concern. And so that was a motivation for us to do this work. And I'll show you sort of 3 motivations on how we got here, and then show you what we've been doing. So everyone knows the high burnout levels, many negative consequences of it. So we really did not want to be adding to it by providing research in the world that says, oh, you should consider doing narratives, and then we were going to exacerbate a problem that is already there. So that was one motivation to do this. 2, there's a lot of work in the National Academy of Medicine, many people trying to figure out what is the intervention for burnout. Many people. And if you look at the data, basically many of the interventions fall into 1 or 2 groups. There's the resilience training branch of work, so we can make our healthcare providers stronger against what's happening to them in the workplace, or we can change the workplace. Let's give them, AI documentation, for example, and that will reduce their workload. To the extent that this might fall in an intervention category, thinking about this as a new potential intervention, but then there's this part that I told you about, thinking about this patient feedback, and there's actually been tension around this, right? So the tension is that when providers are receiving critical feedback, there have been those who worry that it then exacerbates. They become disillusioned. There's psychological pain inherent from their patients that they're not performing for them in the way that they hoped. That is one stream of research. And as a result of that, the industry, for the most part, has actually leaned in that direction and strayed away from having patient narratives be part of what providers see. But on the flip side, there is work that I'm putting here, for example, that says that many healthcare providers did so because they actually wanted to work with patients. And getting positive feedback from patients would actually validate what they're doing and their choices and build their self-worth. And so there's this tension. Should we do this? Should we not do this? And we thought this was kind of interesting to think about what actually happens. And part of that is conditional, like what's in that feedback, right? So my team, this is the conceptual model we've been working with, is that exposure to patient narratives might actually operate on work experience and well-being through 3 potential pathways. And I'm really going to focus today on that first pathway up there, but I will touch a little bit on the next 2. So I'm going to highlight all of them now, which is it's possible that exposure to patient narratives has an affirmation pathway that affects burnout and job satisfaction and well-being generally, which is that in that exposure to narratives, providers are seeing praise through the positive. They might also, the negative may not be all negative. So I'm going to touch on that a little bit more, that in some of these, the negative is also couched with empathy, and that actually might be a pathway that is linked to well-being. You can also see in these narratives a lot of knowledge. So there's a knowledge pathway, and to the extent that people are feeling more confident in what they're doing as a result of what they're hearing from their patients, that might be helpful. And then the behavior pathway, in which we see, and I'll show you that exposure to patient narratives tends to be assisted with providers being inspired to make changes that are coming from their patient systems.
Can I ask a question too?
Sure.
As I recall, right, there's pretty good research that says there are different phenotypes of how you want to receive feedback.
Yes.
And so I'm just curious if that like also interacts as sort of your personal, right? So there are people who we know basically just discount all positive feedback.
Yes.
And they just like, you could just take it out and like they would have, whereas others, it's like essential to have that in there. And so anyway, just you're heading that direction too, but I guess that as this is coming up too, I'm like, it seems like that.
I love that you raised that point about the phenotypes, and we won't be able to, we haven't captured what people's preferences are for receiving feedback, but I think you're right. And in some of the interviews that we do alongside this project, providers talk about the verbal feedback and how important that is. And so we're bounded to this written, largely because this is something that organizations can systematically implement. So we can't make patients say kind words immediately, but we can have organizations put in systems that would allow for written feedback or some feedback. But you're right, the literature, people respond to information in different ways. And that is definitely something we'd like to move towards. So as I said, we're going to focus for the most part of this presentation, given time, we're going to focus on the affirmation pathway. So core premises if there's an affirmation pathway is that healthcare providers have to be able to actually perceive the positivity and the empathy and the narratives. You can think about there being a spectrum. I've thought about many different ways to make this a picture. Spent far too much time on this. This is my AI generated picture. Like, give me green balls, give me this number of balls. So some patients, some providers are going to see largely or all positive feedback. There will be some that will get mostly positive. You can think of the spectrum. Some will get all negative, and that we can pretty much say that probably doesn't feel great. But there are also combinations in the middle that could be interesting to consider and that we consider in here, which is some is positive, negative, and negative with empathy. There's some that is completely negative, but with empathy. You can think about a spectrum and have any number of balls and any permutations that you want, but providers have to be able to perceive the characteristics, the emotional content in these narratives. And then if our premise holds, they're able to perceive it, is it linked to burnout? So we've been studying this in an ambulatory care system, 22 practices across the Northeastern city. We particularly like this setting because it includes primary care and specialty care. It is divided, the system is divided in so that there are low SES, there are practices that are more in low SES communities and some that are higher SES communities, more diversity, less diversity. What they do in this system is they collect the CG CAP surveys. So basically think about it as your closed-ended survey. And what they were doing at the time that we were studying them is that they added on those 5 questions that I showed you at the beginning to their CAP survey, the closed-ended survey. So they collect the data, they send it to all patients, actually. All patients who come through their practice, they send their patient experience surveys out to. What they do is when they get these back, they share the comments weekly. So every week they send out comments verbatim as they are received to the practice site leaders via spreadsheet. It originally was an Excel spreadsheet. They got high tech and moved to PDF in many sites. The site leaders then decide if the staff receive it and who receives it, how frequently receive it, et cetera. So there's variability that we leverage in a lot of our analyses. And in some of the sites, they have these reporting interfaces. So Joanne, you were describing, like, we give them this, right? So this is an example. We published a field experiment. We worked with a design company to develop this, which shows the CAP scores, the standardized, the sort of the closed-ended CAP scores, but also we worked with a design firm to have patient narratives also pop up, and we worked co-designed with the health system, with the providers in the system to give them a template that worked for them. That's not the focus of this, but we have published work that shows that providing an interface actually makes a difference in terms of CAP scores and other things. That's an HSR, that's if you're interested. But what we did for this project is we surveyed staff, and I can tell you more about how, for those of you interested in field research, I can tell you about the logistics of that, but essentially you're seeing the flyer that we used to recruit staff to participate in our survey. The survey was designed to ask about 5 questions that you can see here. Like, how often do you see the narratives? What do you actually see in the narratives? What do you learn from them? How do you respond? And how are you feeling at work? So what we end up with is both a mix of closed and open-ended responses, allowing us to do mixed method work. We ended up getting surveys from 333 people, so 81% response rate. For us, what was perhaps most exciting about this is that we had 43% clinicians. That means that over 50% were actually non-clinicians. And so we had a lot of diversity in our sample, which felt great to us. People responded. This was the first time in this system that anybody had ever asked them about their experiences receiving feedback from patients. And they actually wanted to share with us what they had experienced in that. 77% of those who surveyed said that they had some exposure to patient narratives. We asked them about that 6-month look back window, how frequently they had seen. And in that survey, we asked about burnout explicitly, and we used one of the validated measures for that. And so in our sample, 33% reported some level of burnout, which is pretty consistent with national data and particularly primary care. So, or not just primary care, but ambulatory care settings. And this is fairly standard, but below that red line is you have some form of burnout that you're experiencing in your workplace. I use that scale in my nursing surveys. Exact same scale. It's a good one. It works.
It's kind of wordy, but
It's wordy. And we actually thought about not using it because it is so wordy, but it actually does really work. So we continue to use it in our research as well. We had survey measures for other things, and I'm going to show you those closed-ended survey measures, but we also asked qualitative items. And for example, when I read positive, second question, negative comments from patients about our practice in the past, most often they left me feeling. And people actually answered this question. We actually answered this question. We coded it. We've done many rounds of coding on it at this point, but at the highest levels, we coded it as constructive responses. So responses to that, where we were left, where providers either it reinforced them doing positive behavior or thinking about how they could change negative experiences that were reported. And then we also coded for constraining responses. So responses that gave the indication that people were left feeling skeptical or demotivated. They were feeling discouraged by this. They were not going to take action. So what is it that healthcare providers see in patient narratives? A lot of positivity. And in what we saw, so we looked at this 2 ways. So as I said, we had all the patient narrative data, not just the staff survey data. So we had all the patient narrative data, and our teams coded all of that data. And 60% of what the narratives that they coded were positive. We knew that. Then the survey respondents actually reported 58% of comments that they saw were positive. So actually, their intuition matched what we had actually seen in their data. And 94% of survey respondents reported that they had seen a mix of responses that included some positive. This is actually not that surprising. It fits with other industries as well, but is reassuring. And so we actually just used a sliding scale on our survey, slide over to what percentage is from the 100 to 100%, 0 negative to 100% positive. So what that means is that patients are acknowledging a lot of the positive experiences. They are praising, they are offering compliments to providers in their narratives. There is positivity. And at a high rate, so about 38% of respondents reported above that 70% mark. They're really seeing positive comments come back from their patients. And I should say, this was not the setting in which we were in. Even though I said higher SES, I don't mean high SES, higher than low. And so this was the reason they brought us in to study is because they were having problems with patient experience. This was not a well-performing, off the bat kind of place. So to the extent that they are still getting positive comments back is actually quite telling. And so here's what you see in positive comments. And so to your point that people are still skeptical. So on the right, or the left, you're seeing some of the reactions. So feeling seen, like, great, somebody's seen my effort. Some people report feeling validated. That my work really matters. I can make a positive impact on someone else. Some of the responses are about feeling fulfilled, happy and fulfilled, feeling complete when they get positive feedback. And some are more motivated. So motivated to seek ways to improve my experience because I'm doing pretty well. And they're seeing it. There are, of course, others who respond to positive with sort of negative reactions or constraining reactions, as we label them. They don't believe the data. They think like, this is still biased. It doesn't matter. Like, comments are not representative of really how patients are feeling. And then some that are clearly disbelieving, or management's going to ignore this anyway, so it doesn't actually matter. So you still get a range even with positive, but the majority of responses are constructive. And you can see that if we ask managers, everybody likes hearing positive things and releases those happy endorphins. And so there seems to be a role for giving positive feedback to people. And research has shown that over and over again. Turns out getting positive feedback from your own patients also makes a difference. What was perhaps more, maybe sort of leaned into this from the get-go is we also found, having looked at narratives for a while before we got to this point in our research, is that a lot of it needs affirming feedback in the sense that many patients empathize with staff. So even when there are negative experiences, they are saying, I see you. I see that you're dealing with these hard situations. And that kind of commiseration really seems to matter. So we asked about that in the survey, and you can see here from the 6-month look back window, we asked about, do you get the sense that patients understand the challenges that your practice is facing? They appreciate your efforts. So both the understanding and appreciation, which are two components of empathy, if you go back to original definitions of empathy, they tend to have those two components. And what you're seeing are the percentages there. So 76% of our sample said that, yes, they're seeing that patients understand what they're facing. 89% are saying they appreciate the efforts. And when you ask them, so those are not just saw, but saw it a great deal, you see that 44% are seeing some combination of those things. So that empathy is there. It's there in the narratives that the providers are seeing. When we looked at this, I will show you regression models, but just even looking this unadjusted, when we look at reported burnout and we go down sort of this trajectory of you saw no comments, the people who saw no comments are reporting over 40% of them are responsive burnout rates. If you saw any comments, you get down to 30%. For those who reported seeing a positive mix above that 70%, people scale back down on burnout. If they saw one form of empathy, we get a little bit less burnout. Both forms of empathy. So seeing understanding, seeing appreciation, their empathy in there. And then if you saw empathy and a positive mix, we're now down to below 10%. So we looked at this unadjusted data and started to think, okay, there's the emotional content that is in narratives, even before we even get to the knowledge and we get to the behavior, like just that seems to be linked. We looked at clinicians versus non-clinicians because we had a sample that actually allowed us to look at both. And we see basically the same. We don't see statistically significant differences between those two groups. So to the extent that healthcare is delivered not just by clinicians and the room, but also by those front desk people who are care providers in a different kind of way, they're seeing this also. And a lot of the narratives don't just speak about clinicians, right? They speak about the front office desk staff. They speak about the MAs. They speak about the nurses. And so getting all of those different viewpoints seems to matter. So we also looked at this with regressions. We did OLS. These numbers are too small, perhaps, for you to see. We did OLS regular and looked at empathy because that was kind of one of the interesting ones. And we looked at positivity in the models too. What you're seeing is after we control for the bunch of things that you see here, perceived empathy was predicting burnout in our sample. Of course, you could be worried, and we were worried that maybe the extent to which you're burned out allows you to see empathy. And so we used two-stage least squares models in which we used an empathy jackknife, which essentially means that we calculate the empathy score for the person, taking out that personal from the calculation of empathy, so it doesn't include them in the model. When we do that, we use that predictor to predict perceived empathy, and then we use perceived empathy to predict burnout. And again, you see that perceived empathy is predicting burnout. What's interesting is also in that second column, if you look further down,
In a protective way.
in a protective way, yes. So the more perceived empathy, the lower the burnout reported. Also, did your burnout measure allow you to parse the dimensions of burnout? Like, because it seems like exhaustion versus where you just don't care anymore.
Like,
versus personalization.
Yeah,
because
We just use it for one item.
yeah, we're
Oh,
just
just
using
the
the
one
one
item.
item. So we're not able to do that at this point, but we're doing more narrative work. So
And this is a linear on a 1 to 5, 6 scale.
it's a 5.5.
Five.
Yeah, it's not the full Moss box, but it's free. But it's free.
No.
It's free. It's free for that. Any of you who are budget constrained, it's free. And so what's also interesting to us in these models, though, is we're seeing that positive narratives also operate. We lose the effect of positivity, not lose it, but positivity also predicts your perceived empathy. Right. So to the extent that you're seeing a large number of positive comments, you also think that in there is some form of empathy for you, and that is predictive of burnout. This is.
Can you comment on that prior slide at the bottom? You had the frequency, which for those of us who are running like low budget operations, the frequency impacts the cost a lot. So curious about what your thoughts are on how frequent narrative exposure is needed to actually get these like good benefits.
That's a great question. I can't tell you weekly or bi-weekly. I can't tell you at that level yet. In some of the earlier work,
I was thinking like quarterly, monthly, not weekly.
Okay.
Probably not annually.
Probably not annually. Not with data. My sense is that monthly matters. Partly because I don't know about quarterly. Like, I don't know if you could scale up to quarterly. What I do know is that from the interviews I've heard of, a lot of practice leaders sharing monthly in their staff or in their interactions, and that the frequency of it in that sense has been important to them. Probably the same could be true at quarterly, but I haven't studied that yet. But in some of our first round pilot version of this work, the frequency did predict. So we know frequency can matter. What that ideal frequency is, I don't know the answer to.
And I'll let you go on, but just nuts and bolts here. How are you measuring frequency? Like, what was the range of frequency that you were considering?
We did it on a 1 to 5 scale here, from sort of never to very frequently. Okay. We didn't do it by
Thank you.
I have 10 minutes left. So what I want to do is, what do I most want you to know? If there are questions, maybe I'll pause here for questions. Otherwise, I can skip ahead and just show you a couple of things that I think might be interesting. So look away. Looking through slides makes you anxious. So I'm just going to tell you that we do find effects of learning and behavior change. But maybe something that's interesting as we return to the story about empathy is the value of empathy in negative experiences. So on the right, you're seeing a figure that is showing you the extent to which we coded that people had constructive versus constraining reactions. And on the x-axis is empathy. So for those who saw a high level of empathy in who reported a high level of empathy in our survey, they were more likely to have constructive reactions to the feedback they received versus constraining reactions. The contrast to this is when we look at those who had very little empathy, they reported seeing very little empathy in their narratives. You can see that they actually are more likely to have constrained reactions to the feedback they received. And that's statistically different. Another tidbit that I think is interesting coming out of this work is we have been interested in this question of, does it make a difference if quality improvement efforts are based on those closed-ended scores as CAP scores, which is what is typically fed back to providers, versus patient narrative comments? And I should say that I think of these two things as complementary. So I'm not by any means suggesting get rid of closed-ended questions, but to the extent that maybe it matters that the patient's voice is part of what is coming through here, and like their actual voice of their own words. So we haven't found any effect on burnout of closed-ended survey scores, whether when people report it. So we asked questions of like, do you think quality improvement in this organization is based? To what extent is it based on those closed-ended scores? To what extent is it based on patient narratives, your perception of what's happening in the organization, which form of data or are both forms of data being used? And no effect, no significant effect of the closed-ended reports, but if people thought that the quality improvement efforts in their organization were based on patient narrative comments, we found that they are significantly less. They were at least reported, those people reported less. Correlational, right? This is correlational, but we thought kind of interesting. Why can that be? So when you think about negative valence narratives, what patients say often holds more weight. So these are quotes from people with staff and other kinds of feedback. It gives you a push to make things better. Sure, positive means we're doing great, but the only way you're going to make the positive is you have to get feedback on the negative. So to the extent that healthcare providers want to make improvements, that negative valence feedback can also be motivating. And that I think it's worth noting. I'll just end with takeaways. Skip ahead to that so we can at least have 5 minutes. So what do I think this work says, and what's the direction we've been going with this work? I think it says that it is actually important to consider the narrative feedback from patients and sharing it with staff, that there is potentially an intervention strategy to be had here for improving staff well-being and their patient experience in turn. There are a lot of pathways by which this might be happening. So I'm showing you data today that says that there might be an affirmation pathway, an emotional pathway that we just haven't considered. We might think in a lot of, to the extent that I've been learning researcher in my other life, that learning component is what drew me to doing this project, but the emotions are very clear in this work as well. And so we don't want to ignore that to the extent we've been trying to shy away from emotions or not paying as much attention to the connection between providers and their patients, but yet that's part of the care process. Maybe we should be paying more attention to how that might be affecting each side's well-being and the experiences they have. I think there are implications for health policy and practice. So health policy could think about how to incentivize this. So we incentivize CAP surveys already. What about thinking about narrative data to the extent LLM is available and all of these other things? Maybe this becomes possible to think about how that could be creatively brought into our encouraged. And then organizations, irrespective of whether or not policy moves in this direction, healthcare organizations might well benefit collecting and sharing this data with staff and doing so frequently, to be determined how frequently that needs to be, to what is the minimum necessary to get the benefit. In the organizations we've worked with, we've noticed that they fall in two camps. Some only share the positive information. Some only share the negative information. I think this data suggests that you actually want to share the full narrative and the full story, to the extent that we're able to find and we have elicitation protocols that allow for the elicitation of both sides of the experience. That's actually quite important. So don't forget to share the positivity. People actually want to hear they're doing a good job. Why are we hiding it? Why are we hiding the empathy that our patients are showing for you? Don't just focus on the negative when giving feedback. And also don't focus on failures alone. So the org learning literature, the organizational learning literature tells us that organizations learn when they have information about successes and failure. So you have to kind of package it. And so there, 60-20 rule of like, if you're going to do performance feedback in general, like give some positive, give some negative, right? That appears to hold true in this setting as well. So there are ways in which organizations can do that. So any of you who are practitioner side, there are ways that organizations are doing it. And then I'll just say that for those of you who do patient experience research, I think For me, this has been important because it allows us to connect patient experience to worker experience. I think that we have not done that sufficiently. The value of the consumer as a resource for doing the kind of work we need to do. They are a knowledge source. We shouldn't probably ignore that as much as we have historically. And that there are multiple pathways of influence. I focused on one, but I think the other two are important too. We're now doing work to sort of do the whole story. So that's a little bit of what I've been working on the last period of life. Any final questions?
So are there any questions on the Zoom? No.
Question, which is, I wonder partly what you're seeing is sort of the backlash to having focused so much on measures in healthcare, and that yeah, I mean, this to me makes so much sense. Yeah, what we've heard, all the frustration that sort of managing to measures, and so it's finally like a a way to move away from that approach. I don't even know if there's enough variability that you could study that, or if it's just become so the norm. But I feel like for healthcare workers, that's gotta just be a relief in some ways to see that this isn't just like another number that they're being willing to approve.
Totally. I think it's partly what motivated me to start looking at that question of where do you think your quality improvement efforts are coming? Like, why is the organization making us do this? Is it because of those numbers, or because they saw the stories and patients are asking for it? So I do think there's a potential. We're tired of that. Give me what feels meaningful. Let's give that back. And I think that's partly where we got to with this. And then also when I showed you the template that was up there, we designed that with healthcare providers. We spent time doing focus groups with them to figure out. We went back with the first template from the design form. They said, "Oh no." And where we reached with the organization and with the providers is they wanted that dashboard because their metrics, their target metrics are still caps. But as we designed it, we put those qualitative comments on that first dashboard too. And then you can double click there, you can go through the website so that it's not just anybody could see it on the intranet side of the organization, but it needed to be both in order to deal with, okay, well, here are the metrics, you're measured by that. But also this is what the trends are showing. And then to the extent that we show them both on the page, you can sort of see the trends in both the narratives and your CAP scores. So trying to deal with that and make them complementary. We're not getting rid of the close-ended, and there's value in that, but maybe we can bring these two things together and they tell the story together. Thanks. This is so interesting. I wonder if the findings you present here, if I understand correctly, they're based on clinics. I wonder, do you anticipate things to look different in the inpatient setting? That's the open question. So we're now in the inpatient setting doing this work and expanding it to look at, so when we did this initial work, we were focused broadly on patient care experience. In the new work that we're collecting, for the data collection we're doing now, we are still collecting the full patient experience, but we're also asking questions about the emotional experience of care alongside that, which there is no other way to get that information. So we are expanding to do that. We're collecting close-ended questions and narrative responses about that. Will it look the same? I think yes.
I would guess not, because I think in the inpatient setting, we often now have so much fragmentation, so much changes, shift, that getting the feedback like properly attributed will basically be impossible.
Yeah. Right. That does make complete sense to me. The attribution is hard. And it does mean pushing in a direction that which helps us to let us get there, but sort of the real time sort of closer, right? So the frustration, the frequency question is an interesting one that you raised earlier, because some providers feel frustrated that they get that feedback when it doesn't matter. The world has already changed too much by the time they get it, if it's a quarter or 6 months later. I once had a conversation with a CXO about, is there a way we could do it in the setting, at what point in the setting would that be appropriate? And there are all kinds of rules because HCAPs, you can't collect patient experience. There are all kinds of regulatory rules that would stand in the way of doing a lot of that kind of thing. But our next thing is to think about what an intervention would look like. So more to come on that and what the unit of analysis could be. It would probably be at the unit level in terms of being able to provide. We're going to find out.
For the inpatient, is that including like the nursing staff? That is most of,
That's most of the inpatient.
that's most of
Most
what
it.
patients see daily. Yeah. I'll be very curious in thinking about then how the staff perceive the patient feedback, given the degree to which, at least in our surveys of nurses, they attribute a lot of their burnout and stress to toxic and unsupportive leadership. And so I'll be very interested in, kind of what your data look like if there is kind of to the degree that there is negative feedback from patients, which may or may not be as constructive as clinics, given that the relationships are so different. If the staff internalize that or blame it out differently. Which is where I'm kind of with Bimla. I think it's not I think it actually is unlikely to follow
The same trajectory.
that same kind of relationship because how many times does a nurse even see the same patient twice?
Right.
Jen, at the first time, I think they might.
All right, there's another class that
Yeah,
comes this room.
sorry.
All right, we can go. Girl.
Send any thoughts. This is work in progress, so your thoughts are welcome.